comminuted fractures. Then suture through proximal tibial drill holes. It can be done in comminuted fractures and particularly in children, but it has got technical stiffness. Retrograde screw fixation, which can be done arthroscopic or open with equal ease. Cannulated screw set is needed for this, but the most important thing is a screw has to be of exact length, because when the head of the screw abuts against the cortex only, then it is going to provide compression at the fracture site. It is difficult in comminuted arthroscopic, simplified, only a ACL tibial zig is needed, no special hardware needed, number 5 ethibond and an ordinary washer. We called it ethibond and washer technique. So this is the diagrammatic representation of the technique. So through the arthroscope, we visualize into the knee and we pass 2 guide wires through the fracture fragment. These 2 guide wires are replaced by 2 wire loops. So this is the outside picture, this is the C guide, and how with the help of the C guide, 2 parallel guide wires are put into the fractured fragment. So these 2 wire loops are taken outside the portal, and the ethibonds which are tied to washer are put into these wire loops and they are drawn into the knee joint. And this is the outside picture, how this wire loop is being retrieved outside with the help of grabber. And this is, how we put this ethibond into this wire loop, and both the ethibonds are retrieved into the knee joint with the help of these wire loops. So this is how, when we pull these ethibonds, the washer along with ethibonds, it comes and seats over the fracture fragment, and once we tighten it, it gets tightened into its bed. So this is this small video. So this is the fracture fragment. This is intermeniscal ligament, and sometimes this get incarcerated between the fracture and the bed, and this is this bed which is being cleaned of debris and and once this is done, the fracture fragment is reduced and we put guide wires into it. This is the first guide wire, and in this way we get 2 parallel guide wires through the fracture fragment, and the soft tissue over the tip is released with the help of this probe, so that we can have the smooth passage of the wire loops. And once we have got these 2, we have to replace them by wire loops. This is the first wire loop coming in, and this is the second wire loop in the vision. And once we are going to have these wire loops which are parallel to each other in the fracture fragment, the next important step is to take them outside the knee joint. And it is important that both the wire loops should be taken simultaneously in one go, because if we take them one by one, there is a possibility that some soft tissue may come inside in between them, and it will make the procedure difficult. So these wire loops are replaced by the ethibond, and when we pull on these ethibonds, so the washer along with ethibond comes and it sits over the fractured fragment. So normally, for good tightening, these 2 ethibonds should be facing each other, and sometimes they can come on one side. So it is important that to make them seat properly and in a symmetrical manner. So this can be done with the help of this probe. So here we are adjusting that they should come in a symmetrical manner, and once they are tightened, they take the fracture fragment into its bed nicely. And here we can see that this tightening is done quite well. So in this manner, this fracture is very well reduced, and we can see the shining in the ligament, which can come only once the fracture fragment has seated and there is tension in the ligament. So this is another small video in cases of comminuted fracture tibial spine, because this is a very difficult situation. Sorry. So here we can see that the tibial spine is badly comminuted. There are multiple fragments and it is very difficult to fix. So here we put only one guide wire which goes through the fracture fragment and part of the ACL, and it is not possible to put any other guide wire, because if we are going to put, it will cause further comminution of the fragment which are already comminuted. So instead of that, we put two guide wires through the margin of it, and these are replaced by the wire loops. So here we can see, so this is one wire loop which is, sorry, that's all right. So here we can see that the configuration is different. Instead of two, here we are having three ethibonds. One is going through the substance of the ACL and the fracture fragment, and the two are going through the margin, not through the fragments. So once we tighten them, so all this comminuted fragment, it sits into the bed, and we are going to get good compression, which is not otherwise possible to fix by any other method. So we can see the washer is tight and the fragment has seated in its position, and there is tightening in the ligament. So this is the preoperative X-ray in a child, and we can see the fragment is looking very small. It is very well reduced in the lateral view, and there is a good gap between this fracture fragment and the washer, which shows that the fracture fragment is quite big and the cartilaginous part is not visualized on the X-ray. And this is the anterior posterior view of the same, and this is 8-month-old non-union, and here we can see that the fracture fragment is almost vertical, so it is cleaned, its bed is freshened, and we made the washer to seat over it, and it is very well reduced. So in conclusion, no special expensive hardware is needed. It is simple, it's a daycare procedure. Early mobilization even in comminuted fractures can be done. So thank you very much.
Thank you very much, Amarji. It was a very nice talk. Now this talk is open for discussion.
Hi, Amarji. Nice talk.
Thank you.
Did you ever come across the slippage of that ethibond or slippage of that washer in a follow-up after 6 months? Because I have, in one similar case, the patient is all right clinically, but the washer is gone posteriorly, though the fragment has healed to the crater.
No, we have not encountered, any case like that, though we have fixed, many cases we don't remember exactly the number, but we have never, it may be that during the manipulation while you are doing the surgery, so you might have weakened that, ethibond, otherwise it is not going to break. And normally, if, after 6 months or so, we normally remove it, if the patient is willing for that. Because sometimes if it is bulky, it may cause the impingement in extension. So though the chances are very less, we see, when we have done the surgery at that go, but we prefer to remove it later on. But we have not encountered like it has got separated and it has gone anywhere in the joint.
But in the same scenario, don't you feel that if you take a suture bridge through the substance of ACL while pulling both the trunnion?
I don't know, because we are very comfortable with this, so we don't, we won't like to change it, because we are very satisfied with this technique, in old and in, fresh fractures.
Or you want to change the suture material like...
No, we are happy with it, because we have not, encountered any problems since, long time. Yeah. Okay. Thank you very much. Thank you.
Well, the next speaker is Pankaj. We'll be talking on posterior knee arthroscopic indication and approaches.
Enable content. A very good morning to you all. So I'll be speaking on posterior knee arthroscopy, what are the indications and what precautions to take. Posterior knee arthroscopy is not a commonly encountered practice because all of us are used to view the knee from the anterior aspect, frontal view, but posterior knee arthroscopy can come very handy in case of special indications. So why are we interested in posterior knee arthroscopy? Because Gilchrist said that posterior knee compartment is the litter box of the knee. So in case you suspect a loose body and don't find anywhere else, please go and look for the posterior middle compartment. And another aspect is that posterior middle corner is the single greatest source of diagnostic errors, most commonly the posterior horn of middle meniscus. And it was, in a study, it was said that 22% of the meniscocapsular junction cannot be visualized by anterior portals alone, and this blind spot is reduced to only 8% if you use posterior arthroscopy as well. Just a brief about history of posterior knee arthroscopy. It was started in 1931 by Bowman when he used posterior portals only for drainage. But it was in 1977 when Johnson started using posterior portals for meniscal lesions. So just to take you through the anatomy of the posterior knee, there is a septum. That's the most important structure that we have to appreciate on the posterior side of the knee, which separates the PCL from the posterior capsule. And it is here that there is an important vessel which enters the septum, but we are not interested in this area. Lower 1/3 of this septum is quite safe to be resected, and you can visualize whole of the knee if you take this septum out. Another cadaveric study which shows the capsule and the septum. So septum is a triangular structure, and just behind the capsule are the popliteal vessels. So there is not much space between the PCL and the popliteal vessels, but it is the septum. If you take it down, a lot of space is created because of the fluid distension. So what are the structures at risk if you are contemplated posterior portals? The popliteal vessels, obviously. And then on the posterior medial side, it's the saphenous vein and saphenous nerve, and on the lateral side is the common peroneal nerve. Now if you make your portals with the knee 90 degrees of flexion, both the saphenous nerves and saphenous vein, they go posterior. So it's not very much they are not in very much danger if you make your portals in 90 degrees of knee flexion. Similarly on the lateral side, the CPN is quite posterior if you make your portals in 90 degrees of knee flexion. Now coming to intra-articular anatomy of posterior middle corner, there are three specific folds that you are bound to see if you once you enter the posterior middle corner. This is a transverse fold which is marked by adductor muscle. This is a gastroc fold which is a longitudinal upright kind of a fold, and then there is a horizontal fold which is marked by the semimembranosus. So it is this area which is quite safe to make your portals. So this is a quadrangular kind of a space which can be used to make your posterior portals, and you can easily make two portals in this area. Now how to visualize the posterior knee? You can visualize the posterior knee either by the anterior portals. You can enter the posterior side through the standard anterolateral portals or through the central portal. Or you can make posterior portals which could be posteromedial or posterolateral. And a very special portal that can be made which can visualize the whole back of the knee is a posterior transseptal portal, which we'll be just discussing. So for the theoretical aspect of it, there are three techniques of making posterior portals, but what we are currently doing is under direct vision using a spinal needle and viewing through the anterior portals. You can enter the posterior knee through this area, which is a transnotch area. So that's the PCL, that's the middle femoral condyle. So you can enter through this, and then you can make your posterior portals. So we are going between the PCL, that's the middle femoral condyle, and you can negotiate your arthroscope. This area becomes a little loose if you take the knee into 60 degrees or 70 degrees of knee flexion, and then you can easily negotiate your scope into the posterior middle compartment. So these are the three folds that you see once you enter the posterior middle compartment. That's a gastroc fold, that's a semimembranous fold, and adductor fold is somewhere there. And what you are trying essentially is to enter somewhere here. So you can use trans-illumination, look and with a finger palpation you can palpate the soft spot, and with the help of a spinal needle you can make your portal. And then you can use a knife, 11 number blade to make portal, and then enlarge with a hemostat. So that's an external view. So use trans-illumination to look for veins, because as we know the saphenous nerve, it travels along the vein. So once you have trans-illuminated the vein, there are very less chances of injuring the nerve. Now, what are the landmarks? The posterior middle portal is made, if this is a joint line, it's made at about 1 centimeter above the joint line, just posterior to the middle epicondyle. So another way to approach the posterior knee is to go it's not working. I'm sorry for this technical glitch. It was working on this computer. Yeah. But there are so many videos, so that's what. So the second approach is to go between the ACL and PCL. So that's ACL and that's PCL. And what you find here is loose areolar tissue, and once you go posterior, the septum comes into play, and then you have to resect piecemeal that septum, and then again you can enter the posterior middle compartment. So these are the two approaches to enter the posterior middle compartment. One was the previously that I discussed between the PCL and middle femoral condyle, and this is between the two cruciates. So that's the septum that has been taken off, and that's a little window that has been created, and through that you can enter the posterior middle compartment. And similarly, you can create a posterolateral compartment. I'm sorry, this is going to be a problem. Can we not run from that computer? Sorry, this is going to be a problem. Okay, coming to the transseptal portal. This whole presentation is video based. Okay, so this is the transseptal portal, and you can view from the port. The scope is coming from the posterior middle portal, and that's the area of the septum. That's a PCL footprint, and so through this portal you can visualize whole of the back of the knee in one, just sweeping your scope through the posterior side of the knee. Okay, what are the indications for posterior knee arthroscopy? Baker's cyst decompression, foreign body removal, PCL reconstruction, avulsion fixation, and posterior horn surgery, synovectomy, and just for the sake of completion, meniscal transplantation. Now, coming to Baker's cyst decompression, it's not very often that we need to decompress the Baker's cyst, but if at all we have to, this technique can be very handy. So what you do is you enter the posterior middle compartment through any approach, trans-notch view, and then you make a posterior middle portal. Please bear with me. So, what happens in a Baker's cyst is that it's a one-way valve. So it's a flap valve kind of a thing, and if once you recognize this abnormal opening, you enlarge that opening, and the fluid of Baker's cyst comes out, and then all you have to do is enlarge that opening, so that one-way valve becomes a two-way communication, and the Baker's cyst is decompressed. The other indication is PCL surgery. In PCL surgery, you need to, because we are fully aware that the posterior structures are quite dangerous, and then we have to do all kind of drilling with a posterior scopy. So always keep the drill under vision and the tip of the guide under vision whenever you are doing a PCL reconstruction. So posterior scopy is very useful during PCL reconstruction, and any PCL based procedure, maybe it avulsion fixation or a PCL reconstruction. Synovectomy I'll not run through the rest of the videos. So synovectomy is also not complete unless you do a posterior knee arthroscopy, because synovectomy is to be done in a systematic fashion, and you have to excise or resect the posterior synovium as well. And posterior horn tear can also be repaired quite easily by using this approach. So, but there are certain precautions to be taken. You have to be aware of the anatomy that we have stressed upon. Keep the knee flexed in, during all the position during this surgery, because what happens is the popliteal vessels, they are pushed back in this position, and use transillumination to mark the saphenous structures. Use spinal needle to mark the portals. Always keep the tip of shaver under vision and use suction with great care. The complications are there, so most commonly they are not very severe complications. So saphenous vein and nerve injuries have been reported. There could be cartilage damage, especially on the medial side, because the space between the medial cartilage as well as and the PCL is quite tight. So, but major vessel injury is quite rare, so they only make case reports. So, but if it happens, it is disaster. So, thank you for your attention. I'm sorry for this technical problem, but again, thank you.
Ever used the posterolateral portal?
Yes, I have used, as unfortunately the video was not working, but I had the video of posterolateral portal. Posterolateral portal is easier to make because the space between the ACL and lateral femoral condyle is much wider as compared to middle side. So you can easily enter to the posterolateral compartment from front viewing only, and then you have to be a little careful about CPN, but that is quite posterior. So if you make a high portal, that is not an issue.
Do you switch over to 70 degrees scope?
No, 30 degree scope only.
Any other question? Thank you very much.
Okay, thank you.
So next speaker would be Vikas. Dr. Vikas. He's not there. Next will be the Rajpal. Yeah, please. Dr. Rajpal will speak on the complications of ear.
Thank you, Mr. Chairman, sir. Good morning to all. There has been a...
These slides are not from...
So there has been a steady rise in the rate of the arthroscopic surgery done over the last decade. So as with any other new procedure, there is the initial phase of excitement of doing a procedure which is technically more demanding and in a less invasive manner. And this leads to increased number of surgeries being performed over the time. Gradually, one is faced with a few surprises during the journey, and finally, one has disappointment when he sees that all that glitters is not gold. So, this has been, arthroscopic surgery has been a benign, minimally invasive procedure and has been labeled as band-aid surgery by a few surgeons because of the post-operative two band-aids involved. Over the last few years, due to extensive training, there has been mushrooming of the arthroscopist. Rosenberg stated that arthroscopic surgery is a technically more demanding procedure and has a very long learning curve. So, although the complications are less, but remember, it's not a risk-free procedure. The first paper on complications of knee arthroscopy was published in Journal of Arthroscopy in 1988 by Small, where he, through a questionnaire of 21 most experienced arthroscopic surgeons through the United States, studied over 8,000 procedures and found that the complication rate was more than 1%, most being hemarthrosis. Another recent study from Australia, a level 3 retrospective study, more than about 2 lakh elective arthroscopies over a 9-year period, studied the complications during inpatient while they were admitted to the hospital, and within 30 days of discharge they found the complication rate was 0.64% and most common being DVT. Also they found that the rate of re-arthroscopy due to complications was about 0.1%. A recent study who studied the potential risk factors which could actually predict which patients can have more arthroscopic complications, they found that 2 factors were significant, predominantly increased operative times and a prior operation, any other operation within 30 days of the elective surgery. So they advised that the surgeons should minimize the time and try to delay the elective arthroscopic procedure if the patient has had any other procedure for last 1 month. So I'll try to take each complication. DVT has been most commonly reported, although not as common as an open knee surgery. In an article by Elahi in 2005, the overall rate was about 10%, and there were more significant factors were prolonged tourniquet time, history of previous embolism, and a risk factor for hypercoagulability. So although more reported, but it has not found to be very significant. As you can see that almost 47% have a risk of DVT after ACL reconstruction, but 90% have no symptoms. So current recommendations do not have any conclusive evidence to support the routine use of thromboprophylaxis in routine elective arthroscopic surgery. It is advocated only in high-risk procedures like complex PCL reconstructions or multi-ligament reconstructions and patients with previous thromboembolism or hypercoagulable state. If drug has to be used, low molecular value heparin is the drug of choice. Infection, though uncommon, is around 0.04 to 1.7%. It is more in complex procedures, especially ligament reconstructions and meniscal repairs. Though it is benign, but one has to be very vigilant because it can lead to septic arthritis. A recent paper in 2013, over 4 lakh arthroscopic surgeries over a 5-year period, the reported infection rate was 0.1%. It was found to be more common in males due to reasons which were unexplained and more in complex procedures which is self-explained. So whenever you suspect, always do not hesitate to aspirate, do cultures, start on IV antibiotics. Most of them respond, but you should have a very low threshold for arthroscopic debridement and lavage because these respond very well with such procedure. Whenever you do that in a ligament reconstruction surgery, remove all the implants, especially on the tibial side. Try to preserve the graft, immobilize for a short period of time, put them on IV antibiotics for 1 to 4 weeks, and then on prolonged oral antibiotics. Most of the cases will respond to this treatment. Only a few resistant cases you'll have to resort to open arthrotomy and synovectomy. As with any other endoscopic procedure, broken instruments do form a part of complications of the arthroscopic procedure. We can have broken edge of the blade, broken hook, meniscectomy scissor, hook knives. So best method to prevent is to prevent them. Use only standard equipments which are provided by the standard companies. Do not go for the Indian companies in such instruments. It's a good tip to tie the blade to the handle. You have now available in the market fixed disposable blades, and always insert your instruments with the mouth closed so that they do not get entangled in the soft tissues and may break inadvertently. So if it does happen, do not panic. Immediately stop the inflow, have good visualization. This was a broken probe, a hook, which we tried to retrieve. C-arm comes handy in such cases. If the broken piece goes to the posterior compartment, you can have to use accessory portals, retrieve with another instrument. If a big broken piece is there, try to enlarge the instrument or the portal, and do not leave any sharp cutting instrument, broken instruments inside the joint. If you are not able to retrieve it arthroscopically, do not resort to open arthrotomy. Neurological complications have been reported up to 10% of the total complications. Most common being the infrapatellar branch of the saphenous nerve, which is commonly injured while harvesting the semitendinosus graft. It is as it lies very close to the sartorius tendon. There have been reported cases of peroneal nerve injury after inside-out meniscal repairs. On the unaffected side by the lithotomy position in a prolonged procedure, tunicate palsy. Then the posterior medial portal involves the risk to the saphenous nerve. So best is to prevent them by a precise knowledge of the anatomy. You should pad the bony prominences and the leg holders very well, especially in prolonged procedures. Try to decrease your tunicate time, and there has been a recommendation to use oblique incision to harvest the semitendinosus graft to avoid injury to this infrapatellar branch. Most of these, if they happen, they are transient. They do resolve within 3 to 6 months, and in a few cases you might have to resort to EMG and tendon transfers. So this is the most serious complication that one likes to avoid. Fortunately, it is very rare. It usually is due to a direct laceration of the popliteal vessels, mostly when you are doing a PCL reconstruction or sometimes in a posterior horn of the medial meniscus. So best way to prevent is to visualize the posterior aspect of the joint very well. Avoid sharp instruments like burrs, shavers, osteotomes in the posterior compartment. Try to use curettes posteriorly. Never operate when you are not able to see anything. But if you do have a vascular complication, do not hesitate to immediately call for a vascular consultation. This thought that the collaterals might suffice might give you a big regret later, so always go for a formal repair. Synovial fistulas have been reported. Recently, Christos reported in 2007 4 cases. What is a synovial fistula? It's actually a persistent sterile serous discharge from an arthroscopic portal for more than 7 postoperative days. Usually these are benign and they respond very well to splinting in knee extension for 1 to 2 weeks. And if they are not responding, then you have to go for a formal closure. With the increased incidence of bioabsorbable materials and non-absorbable sutures in ACL reconstructions, the incidence is now increasing. A few cases of compartment syndrome have also been reported, especially when using infusion pumps and acute trauma cases. Although there was an animal study in 1996 which said that even if there is a significant extravasation, the risk is minimal, but one has to be very vigilant. Although most of us do not use pump in knee arthroscopy, try to avoid it. If you are using in acute trauma cases, minimize the tourniquet and the pump pressure. Limit your duration of surgery, delay surgery especially in acute cases, and always frequently palpate the calf, especially when you are doing a PCL reconstruction or a prolonged procedure. You should have a high index of suspicion. When you do have a compartment syndrome, elevate, do not over elevate, keep it at the level of the heart, release all the compressive dressings. You might have to resort to a formal fissurectomy in some cases. So tourniquet, although it is not very essential for knee arthroscopy, but it does have an advantage of improved visualization and decreasing the difficulty. Avoid seepage of betadine and spirit underneath the tourniquet because it does cause blisters. It is recommended that the time should not exceed 1.5 hours and the pressure not over 400. Portal placement, although it is not that important as in other joints in arthroscopy, but especially while making an anteromedial portal, try to visualize it. If it is too high, it might cause damage to the medial femoral condyle. Too low, especially in transportal techniques, can damage the menisci. Too medial lateral can damage the ligaments. Arthrofibrosis, mostly when it occurs, it is due to either a failed reconstruction, misplaced tunnels. Sometimes it can be due to reflex sympathetic dystrophy. So if you find it early, rise followed by a good rehab. Sometimes you might have to resort to manipulation or an arthroscopic adhesive lysis. So tendon ruptures most commonly are associated with harvesting of the ACL graft, the semitendinosis. We can have a premature amputation. If the patellar tendon width is not big, you might injure it while harvesting the bone patellar tendon. Sometimes you can have a dropped graft. The best way is to pick it up, wash it with saline, antibiotic, betadine, and then put it back. And the MCL can be injured while giving excessive valgus, especially when you are using a leg holder or a lateral thigh post. A few slides regarding the ACL reconstruction, which is very commonly done. You can have malposition tunnels, an anterior tibial tunnel, which can cause notch impingement. We can have an anterior femoral tunnel, which can cause a failure in flexion, a posterior tibial tunnel, which can cause a blowout and loss of fixation, and a posterior tibial tunnel, which can cause PCL impingement. We can have, these implants are very fragile, they have to be placed precisely. We can have misdirected implants, endobutton lying anteriorly, posteriorly. We can have proud, transfix, bent implants, and they usually cause a lot of difficulty in removal. Due to malposition tunnels, one can have tunnel widening, leading to failure. You can have intra-articular screws, broken screws, especially the bioabsorbable ones. So friends, complications do occur, they are rare. Ensure that there is early recognition and competent and timely care of these complications, but always remember, communicate regularly with the patient and show concern for the patient as well as his family. Thank you.
Thank you very much, Dr. Rajdeep Par, for giving your talk in time. If there is any question, if there is no question, let's move on. Okay, we had almost concluded the session, but one of the speakers who was missing earlier has reported back, so he will be talking. His name is Rajneesh Garg. ACL reconstruction in comparison of various centers.
Good morning, friends. My topic is fixation of the ACL reconstruct. ACL surgery, it is very commonly performed these days and with a very good results. The goals of ACL reconstruction is anatomical restoration of ACL, early rehabilitation, and return of function to the pre-injury level. There are variety of fixation devices available to deal with the different type of graft, the surgeon preferences and the surgical technique. So it is important for the surgeon to understand the biomechanics and the biological principles of different fixation devices and to use them in a beneficial manner. The graft healing, the bone tendon bone graft, it takes about 6 weeks, whereas the hamstrings will take about 12 weeks to heal. And allografts, they take still longer time. So this is a time when the whole graft construct, the fixation of the graft construct depends upon the fixation device. So the fixation device should secure the graft in the bony tunnel during this time. The current concept of rehabilitation is the accelerated rehab protocol. We want early weight bearing, early return of function, range of motion, and early return to the pre-injury level of the function. So biomechanics of rehab is that the reconstructed ACL, it is subjected to 150 to 500 newtons forces by the activities of daily life and rehabilitation. So according to the studies by Noyes et al., within the first 6 weeks, the graft is subjected to about 2,20,000 of such loading cycles. So when we have used a bone tendon bone or a hamstring tendon, their load to failure is about 3,000 to 4,000 newtons, which is much more than are normally required 150 to 500 newton forces. But fixation has a load to failure of about 500, which is just at the upper limit of a load to failure of the fixation, the whole graft construct. So it is the fixation which is the weakest link in the early postoperative period. There are 3 types of graft motion which ultimately we see. It's a longitudinal, which is called bungee cord effect, the horizontal motion, which is windshield wiper effect, and then there is a elongation of the graft, which is called creep in the graft. So what will this graft motion will do? More than 3 millimeters of graft motion, it will interfere with the incorporation of the graft. It may also cause tunnel widening and excessive motion in the graft, in the tunnel. It will ultimately, it can lead to the premature permanent graft failure. Tunnel widening, it is seen significantly as more in the hamstrings graft as compared to the bone tendon bone grafts. It is more with the non-aperture fixation, and it is due to the biological and mechanical causes. Biological like osteolysis and tunnel widening, and mechanical when we use a bigger screw or when there is excessive motion in the tunnel. So the ideal graft fixation, it should be biocompatible, it should be safe and reproducible, it should be MRI compatible, and it should allow early revision of the graft. It can. Types of fixation, we divide them into aperture fixation and a suspensory fixation. Aperture fixation, which is at the level of the joint, it is by the interference screws. The suspensory fixation is cortical and cancellous. Cortical, we have an endo button, staples and screw post. Cancellous, we have a transfixation pins. The interference screw is defined as a amount by which diameter of the screw exceeds the graft and the tunnel. The advantages of aperture fixation is that it minimizes the graft tunnel motion, there is less canal widening, and creep is less because there is a less length of the effective length of the graft, it is reduced by the aperture fixation, so the graft elongation is less. The factors influencing the interference screw fixation is the length of the screw, the size of the screw, divergence of the screw, torque, bone density distance, and the screw material. Length. A study by Stadmiller et al., they showed that longer the screw, it provides a better fixation. They did a study and divided the patients into 3 groups. In first group, they used a 25 millimeters of screw. The second group, they used more than 30 or more than 30 millimeters of screw. And a third group, they used a 30 millimeter screw with a increased width of 1 or 2 mm. They found that it is the screw length which ultimately decides the pull-out strength. The screws which are more than 30 millimeters, they had a significantly more pull-out strength than screws less than 30 millimeters. So they concluded that the screws less than 30 millimeters of length should only be used when we have a very small bony tunnel. Otherwise, at least the 30 millimeters of the length should be used. Screw diameter also has a significant bearing on the pull-out strength of the graft. In a soft tissue graft, it should be at least 1 to 2 millimeters more than the tunnel diameter. Whereas if it is in a bony plug, with a bone plug, it can be same. It can be same of a tunnel diameter. Then we have an insertion torque. It is more with the resistance is better with the fixation, more with the metal screws. Torque is higher if screw diameter is more. Torque is better if tunnel is prepared by the dilatation method rather than a extraction drilling. So how do we do the tunnel distraction? Under ream by 2 millimeters, and then next 2 millimeters they increase by using the increase the tunnel diameter by using the dilator. So it compacts the bone rather than removing the bone. Then the divergence between the angle is a difference between the angle of the tunnel and a screw direction. It is more common on the femoral side because we drill the femoral side from a different portal and then we put in a screw from a different portal. So this discrepancy, it causes more chances of diversion. So if it is more than 20 degree, it compromises the stability. Then in osteoporotic bone, the strength is weak, so chances of polarity is more, so it is better to use a hybrid technique when we have a weak or a osteoporotic bone. Bioabsorbable screws, we have commonly using these days, we are using these screws commonly these days. The advantages are there is no need for implant removal, there is less graft laceration, does not interfere the MRI, and revision is easier at a later stage if it is a need. But there are increased chances of foreign body reaction with a potential tunnel lysis. It also may break during the insertion and needs a special screwdriver for the insertion. Fixation can be lost early with a partial degradation, and which is about 6 weeks. At 6 weeks we have a 80% loss of strength and 60% loss of stiffness. The incidence of fusion is sometimes more and tunnel widening is more as compared to the titanium screw. Then we have a suspensory fixation, endo button and tightrope. The clinical outcome studies show no difference between the endo button and tightrope. The graft motion is slightly more as compared to the interference screw, which may lead to tunnel widening. So when we have a bone tendon bone graft fixation, interference screw is the gold standard, both on the femoral side and a tibial side, because it is inexpensive, it has a superior strength, it is easier to use, provide aperture fixation, and it has an excellent stiffness and minimal slippage after cycling. Staples and screws and posts, not commonly used for BTB graft, mainly used as a salvage technique, because if we use a screw or a staples, we use a staples, we can create a bone plug fracture. Endo button, it is also only used as a salvage procedure when we have a posterior femoral tunnel blowout. Soft tissue fixations of tibia, staples, either single or two staples. Then we have a screws and post with the spiked washers, and interference screw, which we are most commonly using these days. Interference screw fixation, especially with a bioscrew, needs a slower rehabilitation, because when we using this interference screw, especially on the tibia side with a soft tissue graft, chances of slippage is slightly more as compared to the other fixations. So hybrid fixation is preferable. What about tibial versus femoral fixation? Tibial fixation is less secure because the bone density is less and bone strength falls rapidly when we go away from the joint line. And the angle of force, when we on the tibial side, it is directly in the line of the graft, whereas on the femoral side it becomes directly in the line of graft when there is a flexion of 110 degrees. So conclusion, in the early postoperative period, fixation is the weakest link. Tibial fixation is at a greater risk of failure. Clinical results of various methods are comparable. Aperture fixation, theoretically it is better than the suspensive fixation. Interference screw are the gold standard. Hybrid fixation is becoming more popular. Thank you.
Well, thank you very much, Dr. Rajneesh. Is there any question to him from the audience? Yes, there is one, please.
So initially, it was told that the aperture fixation is always better, and we resorted to bioscrews. Now the word is shifting from the bioscrews and more towards suspensory fixation. So where exactly we lie today as of now? It's better to bioscrews.
When we using a aperture fixation with the bone tendon bone graft, it is quite secure. But with the soft tissues, that as compared to the staples or the screw post fixation, the chances of slippage is more, and because of the biodegradation of the early biodegradation of the bioscrews, so that this construct, their chances of becoming weak after 6 weeks or 8 weeks. So it is always better on a tibial side if you can additionally fix it with staples or the screw post. So on the tibial side, because there is a decreased bony density, bone is weak, the bioscrew gets early degraded, and chances of slippage this is more. So a hybrid fixation or a double fixation will be preferable, especially if bone quality is little low.
That answers your question.
I would like to hear Dr. Basin, please, if he wants, because he has an indigenous technique.
Hear you on his question.
Sir, he has rightly put it, sir. Sorry for coming here, sir.
Please.
He has very rightly put it that for a cortical graft, it is still acceptable. The difference is that endobutton is basically relying on cancellous cortical bone, but the bioscrew is relying on cancellous bone.
So you recommend hybrid fixation in tibia?
Hybrid fixation means that you use a
Bio as well as a staple or a post?
Double fixation you can say. Or additional fixation.
yeah, that is now a standard recommendation, although I may not be using it. I use only a post. Personal experience is, which is not less, which is about 18 years, is only a post on the tibial side. But definitely, because that interference screw is not as secure, so people have added a post or a staple. People have added. I think it's not a bad idea, especially if you are using a bioscrew.
The strength and the stiffness quality of a post and washer is on the tibial side, it is more than the interference screw. But though we are using interference screw more commonly, but strength and stiffness of washers and screw posts, they are more as compared to the interference screw on the tibial side.
Well, thank you very much.
Thank you, sir.
That brings us to the end of this very fruitful session on arthroscopic symposium. I'm sorry, Dr. Basin, to stop you in the beginning.
No, sir. Thank you.
We thought we may not be able to complete the session in time, but we are still having 10 minutes. So, thank you all the speakers and the audience. We conclude the session.
Sorry, sir.